Hello, Oleg. Hello, Oleg. Can you hear me? Hello, testing. Yeah. Igor, good day from Miami. Well, greetings. Don't be afraid to talk. Good morning, Ming.
Good morning, John.
I'm staying off camera here
Yeah.
doing, yeah, let me make you administrator. What I do is, let's see here, make you like a co-host.
Okay.
And, okay, yeah, let me, I'm also on my YouTube here, which is a mistake. Yeah.
Okay. I think the webinar will start 30 minutes. In 30 minutes.
Yeah.
John?
Yes.
How are you?
Good. How are you?
Fine, thank you. We are ready, okay?
Okay. You are presenting, right?
Yes, I'm presenting, yes.
You are presenting?
Yes, yes, I'm presenting.
Oh, great, great, great. You came early. That's great.
Okay.
Let me, so you've done the PowerPoint before, right?
Okay.
Have you done PowerPoint before?
I already done, yes.
Oh, okay. So do you have any videos in your presentation?
No, I don't have any video, just the photos and the PowerPoint photos only.
Okay, okay,
Okay.
very good.
Okay, I'm waiting.
Okay, thank you.
Okay, good.
Thì nói tóm lại là trong cái đường cong góc đó, cái điểm mà tốt nhất là điểm mà đạt được là cái sen và cái sphere cao nhất đây không phải là sen cao nhất của sen của cao nhất của từng cái, mà cái cặp đó nó phải cao nhất trong cặp còn lại. Đúng rồi gọi là tối ưu nhất ấy.
There you go, Adnan. Dr. Adnan. Hello, everybody else. We're just setting up now.
There is nobody else. Just me and you from the speaker.
I'm sorry. It's my hearing is not great. What's that?
Do you hear me or not? My voice
Yeah,
is
I
loud
hear you.
or
I
not?
hear you. You're loud and clear.
Okay.
Okay.
There is no other speaker, just me.
No, there's 3 others. There's 4 speakers.
Okay. We are 20 minutes to start, yes?
Yeah, we have about 20 minutes.
Okay.
I'd like you to meet someone next to you, Ming. say hello to Dr. Adnan.
Hi, Dr. Dan.
Hi. Hi.
How's it going?
Nice. How is China?
Yes, China right now everything is going well.
I hope so that I hope Corona will go out.
Nearly virus haven't affect too much for our life.
Wish you best.
Yeah, maybe it's not good, not bad, just so.
Inshallah. There is where it will go out, inshallah.
Okay. Have you visited China before?
I would like to go to China, but you know, it's difficult these days to travel to China or to travel anywhere from our country. We are in a war, so there is restricted for traveling and everything.
Okay. Which city are you in right now?
I am in the capital, Sana'a.
Sorry, can you tell me again?
Sana'a, the capital of Yemen.
Oh, Yemen.
Capital of Yemen, yeah.
Yeah, that's good.
Yeah,
You know Yemen?
we've had some good conferences there in Yemen.
Yeah, I think 1 week ago or 2 weeks ago, you
Yes.
have the conference
Before
there.
2 weeks, yes.
Yeah, Ahmed's here. Ahmed, hello. Are you there? Ahmed, he ran it.
Yeah, hi, John.
You remember him? You know Ahmed, I'm sure.
Yes, we know.
Yeah. Where's your camera, Ahmed? You don't have one today?
We have no one, and we have no camera maybe today.
Oh, okay. Well, the chairman, Oleg, are you there? Alexander? He's I'm chairman of the Ukraine Neurosurgery Society, I believe. Oleg, are you there?
Okay.
I just want to make sure your camera's working, Oleg. Hello, Dr. Tarek.
Tarek Ali. Hello, Dr. Tarek Ali. Hi. How's it going? No, we can't hear you. I can't hear you.
Open your speaker, Dr. Tariq.
Okay.
I think he has a problem with connectivity.
Dr. Tariq, you're connecting, yes. Tell me.
Oh,
Maybe he has a problem in his mic.
I think Dr. Tariq should leave this meeting and rejoin again.
Okay, you can disconnect and reconnect again.
yeah, is Oleg available? I'd kind of like to go over a few things. Oleg. I
Put
believe
down
the chairman of the Society of Ukraine.
But Alexandra.
Alexandra.
Hello, Professor Alexandra.
It sounds like Alexander in English.
Hello, Dr. Tarek Ali.
He's still in having trouble with connectivity.
Have some problem
To
of
me, came to my he's in the room. He can't say hello from my camera. Dr. John.
Okay, I see. You are colleagues.
Yes, yes. He's with me in the same. Tarek.
Алло. А что вы пересиживаете на работе?
Потому что все работает.
Okay, Oleg, are you Oleg?
But your name is John Bennett.
Не, вы
Yeah, I
там.
know. I don't know. Understand that really.
Ну вот же зайдите, оно открыто. Zoom.
Same name to you, John.
Сюда.
Yeah, I know. Took my name.
Ну, вы хотите потренировать
Funny.
Я бы хотел узнать, я там или нет.
Ну вот.
That's fine.
Да.
Закрыть?
Да. Вы тут. Вот ваше лицо. У вас включен микрофон, вы можете с ним пообщаться.
Hello, dear friends.
Hello.
How are you?
Oh,
I am
Oleg.
Anatoly.
Okay. Finally, hi.
Odessa.
How you do- I'm John Bennett. Nice to meet you. Now, Oleg.
Yes, Alexander.
Now, yeah, oh, hi. Oleg, is that you?
Yes, yes, one moment.
Can you hear me okay?
Yes, I hear, okay, and you?
Yeah, okay, let's just go, yeah, I'm John Bennett. Let's just go over the order, okay, of the speakers. Do you have an order or does it matter to you?
No,
It doesn't matter, it's whatever order?
no.
Do you understand what I'm saying?
Начинается.
Not everything, I'm sorry, not everything.
Can anybody understand what I'm saying?
Yes, we are understanding.
Yeah, who is going to be first speaker, Oleg?
I think maybe Dr. Adnan. I read.
Okay,
Okay, I'm ready. If you
Okay.
want me to start, I will start.
yeah, that's fine,
Okay.
that's fine. So, and the other speakers, are the other speakers here?
Tone. I see. One moment, I will give a call to
Yeah, I would just,
Yaroslav.
okay. Yeah, we have 10 minutes, so we have time.
Алло, Ярослав, так підключайся. Тут уже в групу, просися в групу, тебе включить групу учасників. Давай, швиденько, да.
Не працює. Не працює.
А у вас тут это, окошко открывается?
Конечно, открывается. Давайте я тут себе сейчас уберу. Вам буду поправлять. Ой, пожалуйста.
You just bite your nails at the end. Wonder if people are gonna come in. A lot of people wait till the last minute. No, yeah, no, I mean, why show up to a meeting early?
Hello, Dr. Alexandra. How are you?
Good, good, thank you.
How about the situation in Ukraine hospital?
Situation, it's a real war.
How about the neurosurgery department? The work is more heavy right now.
Sorry, what?
How about the patients in the neurosurgery department right now?
Yes, we have both. We have our planned patients. Also, we have wounded patients from the war area. We both take care about both of them. But we are not on the first line. We are like not even second, but third line. We care about most difficult cases with chronic cases and some patients come for rehabilitation. That's all. So three groups of patients.
How about the tumor patients right now?
Yes, we have almost every day we do our oncology, neuro-oncology patients.
Okay.
Not so many traumatic cases. Maybe some hematoma, hydroma, some drain. So it's mostly not so much surgeries, but manipulations, like manipulation, some functions, some evacuations. So follow up this difficult patients. I can see Yaroslav is joining us. It's good.
Hello, dear colleagues. Hello.
Welcome.
Thank you.
I'm sorry, sir, I don't understand Cyrillic. Could you please introduce yourself? I'm John Bennett of Neurosurgical TV.
Yes, I think everybody knows you. It's a very
Oh, yeah. I'm not a neurosurgeon, but I like the internet and I like neurosurgery. Well, listen, yeah, we're just waiting for, let's see, Sammer. Okay, Sammer's coming in. Sammer's from Iraq, and he's going to be our moderator, more or less. But we have 5 minutes. We have 6 minutes, actually.
6 minutes, yes.
Yeah, Alec, anytime you want to do a webinar, we do it, okay?
Yes, thank you very much for your support. It's really very valuable.
It's our pleasure. It's our pleasure.
Thank you. I think we will go on maybe in interval from 2 weeks to 4 weeks.
Okay.
We will collect the topics. I will ask you for some to invite some lecturers because you have
Okay.
contacts. Also, you can
Okay.
use my contacts. I can help you if, especially the specialist in neuro-oncology and neurovascular surgery. I have many friends in Europe, so also I can ask. I have my portfolio is quite big also. So usually in normal time I attend up to 10 congresses per year with different talks.
Yeah, I communicate well with Anya. Anya?
Yes.
Yeah, I communicate well on WhatsApp with her. I'm communicating with her now, during the webcast. So if there's problems, I'll just tell her. Video or audio problem, something like
John,
that.
could I say something there?
Yeah, go ahead.
First
First,
of all,
introduce yourself. And where's your darn camera? Come on.
okay, just a minute. I hope you can see me now.
There you go.
very well.
Okay.
Okay. First of all, I'm gonna introduce myself for the attendees. Here is Ahmed Al-Ghanimi. I'm marketing administrator at Abdurrahman University of Neurosurgery, which is considered the first online academic degree in neurosurgery worldwide. Actually, on behalf of Professor Salim Abdurrauf, I would like to show Ukrainian neurosurgeons an opportunity for collaboration with Abdurrahman University of Neurosurgery, either for conferences, webinars, or anything related to neurosurgery. So I wish they can respond for this opportunity and this offer as soon as possible, or at least after this meeting.
Okay, thank you. Let us contact and let us collaborate with pleasure. With pleasure.
Yeah, he put together a great conference, a couple of them. We had a lot of Yemeni neurosurgeons. It was not broadcast locally and on the internet. So that was a good conference. Okay, we have 3 minutes, about 3 minutes. Now we have one speaker here. Do we have the second speaker or third speaker here, Oleg? Are they here yet?
I can see the 2 speakers from Ukraine and doctor from.
Okay. Samer is going to moderate because yeah, he has experience in war, so
Good.
there's the Warlicks. Here's the moderator for us. Warlicks, how you doing? You need to unmute.
Hi, everyone. Sorry.
Welcome.
I think water like from Calanda, I think.
Hi. Good. Actually, you have to take good morning from Thailand, everyone. It's been a long time. Sorry, I just do my tooth extractions.
Yeah.
Okay.
Welcome, Warlicks. One time as usual. So Warlicks, the way we're going to work it is basically you introduce Samer. He's coming in a minute, and since he knows war trauma, he's going to kind of moderate. Okay. So you kind of Warlicks, you just kind of introduce. We'll talk about the show and then introduce Samer. Okay.
Okay.
Yeah.
Okay. And he'll kind of, decide the order of when to take questions. And of course, you take care of the whole thing. You make sure it doesn't turn into a disaster.
No, it's not.
It's your job for that. Okay, 1 minute.
It's nice to be back again.
Yeah, you haven't been on live for a while. We'd like to see more of you. I mean, I didn't mean it that way.
I have to like stay away from the social media sometimes just to do the actual work at the neurosurgeons and neurovascular. I just set up the neuro intervention in my hospital, so it's quite busy a little bit. Yeah.
Okay, are you ready? You ready, Warlocks? Samar's not here yet. Samar, you here?
I do not see him here
No.
yet.
Well, I guess we have to wing it. Okay, so the first speaker, you know the first speaker there. You got it written down, right? Adnan, Dr. Adnan from Yemen.
Oh, you changed? So
Yeah, no, Adnan, Dr. Adnan's going to be first.
okay, and
Yeah,
next.
the order was changed. Yeah. Okay.
Oh,
okay, here we go, Warlocks.
Sure.
You ready, Warlocks?
Okay, okay.
Okay, hold on. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1.
Hi, welcome to the Neurosurgical TV. Today, we really have an honor to online the webcast that today we have an honor from the Ukraine Neurosurgery Grand Round, in which today the main topic about the management of the military's neurotrauma, in which is really like, you know, a main topic right now, and we have ethics for like, you know, the world. So today we have four like well-known like speakers from different countries. So let me introduce Dr. Samar Hurst. He's the famous neurosurgeries in which he specialized in neurovascular, and I have like followed him, and I like read. He wrote the textbooks, and I saw his a lot of his videos, and then I follow him. So he's going to be the modelers today. But so as Dr. Hoss is not here today, maybe we will start with our first like speakers. It's Dr. Adnan Abdullah Alawadi. I'm sorry if I pronounce this wrong. So he's from Yemen. He's going to give a talk about the penetrating head injuries. So please welcome Dr. Adnan.
Hi, everybody. Nice to be with you today.
Something wrong?
Okay, Adnan, Dr. Adnan.
Dr. Adnan, can see.
It looks like are you there, Doctor? Okay, there you go. You get that. Hello, Dr. Adnan. You there? Maybe the connection.
Dr. Adnan, switch on the microphone. Your microphone is switched off.
Yeah.
Turn it on, please. Microphone, micro.
We'll get it. Okay. On the way. Okay, we're on. So, sorry, it might be the internet. Oh, there we go. Can you hear me, Dr. Adnan? You're muted.
We can't hear you.
Professor, you are muted. Okay. I'm gonna just contact him soon.
Yeah.
Oh, he's still mute.
Yeah.
Can anyone talk?
You know, there's no way to get in touch with him. We just
can
have
you
to keep
unmute?
our fingers crossed that he looks at us. Dr. Adnan, can you hear me? Can you hear me? Oh, Dr. Sammer's here. Dr. Adnan?
You hear me?
Yeah.
Do you
Hi,
hear
Dr.
me?
Adnan. Oh, yes, we hear you. But however, that I think you just closed your microphone. So maybe you can
Maybe
you
it's
start?
incidentally closed. I will
Oh,
start
yeah.
from the beginning.
Yes,
Okay,
please
yeah,
start.
sure.
Please start.
Yes. Thank you very much. Yeah.
Okay. You hear about our declaration or Dr. Alexander? Dr. Alexander was our mentor in neurosurgical department at Tauram Modern General Hospital in Sana'a. He was passed away before 1 year. Peace be on his soul. He's from Ukraine. And he gave us a lot of information and teach us very informative information about the peripheral nerve surgery in Yemen. I have no declaration. This I said that penetrating brain injury was one of the devastating injuries result from firearms, and 14%, and penetrating brain injury are a major health problems we are facing in our country, dealing to war in war cases or in civilian gunshot injuries. Many deaths are due to gunshot wounds to the which are most lethal. These injuries are included passing through the central region of the brain, zona vitalis, which include the supracellular and compressing the ventricular third or thalamus and hypothalamus. Fatal trauma is related to the head associated with additional injuries to other parts of the body. There is a well-documented series have demonstrated decline mortality from severe head injury from 50% in 70s to 36% in 80s, and possibly even lower in current days. We classified the penetrating head injury or the trauma head injury to either or to severity or to morphology. From the mechanism, we have closed and penetrating head injury. By severity, we have, according to Glasgow Coma Scale, to mild, moderate, and severe head injury. And to the morphological type, we have skull fracture or intracranial lesion, depending on the is local or diffuse, epidural, subdural, intracerebral, and mild to diffuse axonal injuries in diffuse type of intracranial lesion. Penetrating brain injury can be caused by gunshot explosion due to shrapnel, by airstrike, bombing, etc. And shrapnel object trauma by knife, sword, or scissor, etc. to the brain or to the head. We are classifying the penetrating brain trauma either to penetrating or perforating and tangential brain injuries. In perforating type, we have an inlet and outlet site that pass through and through the brain, which are the most devastating and lethal type of brain injury. The other type is this is one example for the perforating. This is the inlet and this is the outlet. The outlet is mostly larger, and this is the CT scan of the another patient. So the inlet and outlet and the outlet, which is the transcranial and hemispheric brain injury. For the penetrating, we have only inlet and we don't have outlet. For example, this example from an explosion of inlet with the foreign body inside. This is also one example. This is another example for gunshot to the brain with the bullet still inside the brain parenchyma. This is also another kind of penetrating brain trauma by scissors starting to the head of one adult male. This is the CT scan of the same patient with the scissor scan. Show the metallic foreign body inside the brain parenchyma. I have another case for stabbing of the head by a sword or by a knife to the frontal head. And this is the CT scan of the same patient. This is a metallic foreign body post expulsion in a pediatric patient in the frontal area. Still chronic. And touching type of injury, we have penetrating object does not reach the skull, but it can cause an injury to the brain parenchyma. And this is an example for it, a tangential to the neck with an entry point in the occipital area and output entry in the periauricular area and the exit in the occipital. We have severe brain edema and bone loss from the occipital area. The management is challenging topic, which divided in pre-hospital or at the field. We will see that in the military hospital, they have less mortality than in civilian casualties, because they have the first line first aid management for penetrating brain injury, and there is also they can deal with the mass casualties from our side. From in pre-hospital care, it's very important to decrease the secondary brain injury and to achieve the maintenance of the airway, optimize oxygenation, ventilation, and cerebral perfusion. This is a guideline for the field management of combat related head trauma, which is published from the Brain Trauma Foundation, and also it's found in the web, which gives details for how to manage penetrating brain injury in the field, depending on the Glasgow Coma scale, and when time to evacuate from the field or no, and it's depending on if there is benefit from the evacuation, rapid evacuation, or to maintain and advanced life support in the field before transportation. After transportation of the patient to the emergency department, in the emergency department, we have to keep doing the supportive treatment for the patient, correction of hypotension, hypoxemia, and to deal with the coexisting trauma, control of any associated hemorrhage, and correction of traumatic coagulopathy, urgency scan, head of neck, and tetanus toxoid, neurological consultation, and to avoid excessive steroid or steroid medication in the ER. Surgical management. Surgical management was developed from recent years. In the 18, it was only developed for management by Harvey Cushing. Dr. Harvey Cushing developed from approach to management of penetrating head injury and advocate complete removal of metallic and bone fragment, as well as circumcraniotomy and to create transintracranial pressure. This philosophy was dealt with until 1918 during the Israeli-Lebanon conflict, where it shifted toward the conservative debridement maneuver. In most recent conflict in Afghanistan, Iraq war resulted in future reinforcement of surgical management, which trended toward daily decompressive and conservative debridement. Sorry. In 1988, the International Brain Association and Brain Injury Association and the American Association of Neurosurgery have published guidelines for the management of penetrating brain injury, which was published in 2001, which is the attempt for a medical and surgical management of penetrating cerebral debridement, minimum debridement, decompressive, and neuroplasty. This is an example for a simple debridement with decompression and debridement of the brain and neuroplasty. We have some which has to be dealt with in traumatic brain injury, which have a prognostic factor, including a Glasgow scale, age, pulmonary size and reflex, hypotension, and CT5. These are all are published in the Trauma Health Trauma Foundation, Brain Trauma Foundation, and can be reviewed there. It's out of our topic to be discussed here. But in hurry, we can get that Glasgow scale. Have class 1 evidence that strong relation with decreased Glasgow scale with the Glasgow outcome scale is very important. And at the age, there is increase in the mortality rate or the Glasgow scale rate with increase in the age. And pupillary reflex, if there is absence and fixed dilated pupil with absent bilateral pupillary reflex, is associated with bad outcome. And hypertension also, and CT finding, which included brain edema, traumatic subarachnoid hemorrhage, blood in the basal ganglia, in the basal system, or extensive subarachnoid hemorrhage, and Fisher guide for CT scan information about the subarachnoid hemorrhage. There is one important thing in mass casualties incidents, how to deal with the mass injury incidents in war conflict in civilian patient or terrorist attack in a civilian patient. You have a algorithm for management of this patient, depending the ability of the resources, neurosurgical facilities, and the condition of the patient. If the condition of the patient is less than 8 Glasgow scale and have no brain stem reflex or absent corneal reflex, to be kept just for observation until if there is improvement or there is indication for surgical intervention like midline shift or the Glasgow scale is up to 8, they can be taken for neurosurgical intervention. Our study was dealt, we have done in our institute at Thawra Modern General Hospital at 2017 for 3 months and observation for 6 to 1 year, 6 months, 1 year for patient post penetrating brain injury. We are have an objective for characteristic and pattern of patient with penetrating brain injury. The study relation between admission, Glasgow scale, and modalities of management and outcome. Patient and methodology, retrospective cases series, descriptive study, in December to March 2018. We have 51 cases. We depend on the Glasgow scale, Glasgow outcome scale category, death and patient vegetative state, 3rd degree severe disability, and moderate disability or good recovery. This is the modified Glasgow outcome scale, which was developed in 2020. Our results, we have 51 cases. Their age range between 2 and 55 with mean age of 23 years. Male was 90% of them were male and 10% were female. The mechanism of injury explosion was 63%, 92 were from gunshot and about 8% from stab wound to the brain. Perforating injury were about 29 with penetrating injury about 53% and 18% for tangential brain injury. Time of arrival, there is the early arrival about 55%, which is 1 hour to 6 hours from time of injury, and the late arrival was more than 6 hours from time of injury. The Glasgow scale, most of them were having good Glasgow scale at 55% with Glasgow scale 13 to 15, and 35% were having low Glasgow scale. The pupillary reflex, most are have different presentation from normal to constricted, dilated, non-reactive, or dilated reactive pupil. There is some patients with have the unilateral dilated pupil, and the other side was normal. Associated injuries, ophthalmic extremities and the chest maxillofacial. Site of injury, the frontal area was the most common, followed by parietal and temporal area. CT scan finding, besides skull and dural injury, there is intracerebral hemorrhage, foreign body edema, brain laceration, and subarachnoid hemorrhage, pneumocephalus contusion, and so on. The foreign body type was mostly equal between metal and it was represented by 35% and bone by 17%, bone and metal, sorry, and bone only on 14%. This is the distribution of foreign body. It was distributed either all the three layers from the skin up to the deep tissue, or only in the deep tissue or superficial in the brain. 88% of our cases were dealt surgically, and only 12% were dealt in a conservative manner. The conservative manner also includes any cases what was dealt with skin closure under local anesthesia. If we use a general anesthesia, we described it as under operative treatment management. The complication were CC was the CC plaque, followed by convulsion and deep infection, superficial infection, and hydrocephalus. There is another complication as rebleeding and re-expanding hematoma was in that series of the others. Most affected group were 21 to 30 years and 11 to 20 years, with expulsion is the most common, followed by the gunshot and the stab wound. In the gunshot, 11 years to 20 years was the most common affected age, and the expulsion as the most affected age group was 21 to 30 years. This is the distribution between gender. In the female gender, we only find that they have gunshot wound only in female, which are aged from 11 to 20 years. And also in female, we have only expulsion affected female patient under 10 years old, 50%, and the other 50% in 20 to 30 years. This is the most type of injury, penetrating injury to the brain, with perforating injury and penetrating injury were the most common. And second age group from 11 years to 20 years with penetrating injury is the most common, also in the 21 to 30 years. Here we can show that Glasgow scale was in the most common age types from 11 to 20 and 21 to 30, with the most of 10 cases for each group. The frontal area of site of the injury, depending to the age of group, in a patient with more than 40 years only have frontal injury, and the posterior fossa only was seen in age from 31 to 40. This is also a table explained the relation between the age group and the operative type. There is more extensive debridement and minimal debridement were done. More minimal debridement done in 19 patients, which equal to 37.3, and followed by minimal extensive debridement in 17 patients. This is a CT finding which correlated with the CT scan file, which correlate to midline shift and the Glasgow scale, which show that the subdural hematoma and the subarachnoid midline shift and numerous significant statistic relation to CT scan finding. On the other side, constricted pupil, dilated and reactive or non-reactive pupil were 100% seen in cases with glaucoma scale less than 9 with significant p-value. The overall outcome scale were good recovery and 43% and 29% disability, 14% in severe disability, 4% in vegetative state, and 10% with mortality. There is a significant statistic relation between type of operation and glaucoma outcome scale only in group with low glaucoma scale with operated have been done for them had a better glaucoma scale with a positive or significant statistical p-value. This is the relation of the CT scan finding, the glaucoma outcome scale, where dural injury and subdural hemorrhage and edema midline shift have a significant relation to the glaucoma outcome scale. And relation to CT scan finding to mortality, there is interventricular subdural hemorrhage and venous sinus have a positive or statistical significant value for CT finding related to mortality. In the type of management, we have found that, as we said before, that only in glaucoma scale less than 8 operative times will have a strong relation to the glaucoma outcome scale. And glaucoma scale have good results or better prognostic or good prognostic factor for glaucoma outcome scale with 71 for recovery in mild glaucoma scale and 11% recovery only in severe glaucoma scale patient presented after penetrating brain injury with significant statistical value. Also, there is a significant relation between the glaucoma scale and mortality. This is the mortality rate depending on the age group, which show that mortality only seen in age group 10 to 20 or 21 to 30, which are the most common involved in the conflict or in the explosion or in civilian armed fire conflicts. This is the relation of pupil size to the glaucoma outcome scale that we described before, that if the pupil is dilated, non-reactive, and absent light reflex, have a strong relation to the glaucoma scale with a significant p-value. Perforating injury had the worst outcome, with only about 7% had a poor recovery compared to 48% poor recovery in penetrating injury, with a significant p-value. 60% of mortality were caused by penetrating injury and 40% by perforating injury without significant statistical results. There was no relation between the pupillary size reflex to mortality or management type, or there is no relation between the management type and mortality, no relation between time of arrival to glaucoma outcome scale or mortality, no relation between the mechanism of injury to glaucoma outcome scale or mortality, and 60% of mortality was post-extensive operation. 60% with glaucoma scale below 8, 20% of each minimal, and skin closure under local anesthesia, 100% were with glaucoma scale below 8. No relation between associated injury and mortality with glaucoma scale or glaucoma scale with the non-significant p-value. This is summary for our study. I know it's a long topic, but I will give you my summary. It's a 51 case, 90% were female, male. Their age range between 2 and 55, with the main age 23. 63 explosion, 29% gunshot, and stab wounds. 39 were aged between 20 and 30 years, followed by the age group between 10 and 20 years with 35%. Expulsion was the mechanism of injury in patients less than 10 years. And 53% penetrating, 29% perforating, and 18 tangential type of injury. 55% present early, 1 to 6 hours of injury, and 55 with Glasgow scale 13 to 15, and 35% Glasgow scale below 9. Ural injury, subarachnoid hemorrhage, edema, midline shift had a significant statistical relation to Glasgow scale, and subarachnoid hemorrhage, subdural hemorrhage, midline shift, pneumocephalus had a significant statistical relation to CT scan finding. The dural injury, subdural hemorrhage, edema, and midline shift had a significant statistical relation to Glasgow outcome scale. Concentric, dilated, reactive, or non-reactive pupil were 100% seen in cases with Glasgow scale less than 9. The site of injury, 70% were frontal, followed by parietal, and 31 temporal, 16 occipital, and 6% posterior fossa was involved. 88% operated, 33 extensive debridement, 37 minimal debridement, and 18% skin closure under general anesthesia. Complication were 10% safe and convulsion, 8% deep infection, and 6% superficial infection, and 4% had hydrocephalus. 43% had full recovery using Glasgow outcome scale, 29% moderate disability, 14% severe disability, and 4% vegetative state, and 10% died for mortality cases. 60% of the mortality were caused by penetrating injury, while 40% caused by perforating injury without significant statistical results. 80% of the mortality caused cases were with Glasgow scale below 8%, below 8 score. Perforating injury had a worse outcome, with only about 7% had a full recovery, compared to 48% full recovery in penetrating injury. The better the Glasgow outcome, the Glasgow scale, the better the Glasgow outcome scale. 71 full recovery in mild Glasgow scale, which is 13 to 15 score, and only 11% recovery in severe Glasgow scale, which is less than 8 score with significant p-value. Significant statistical relation between type of operation and Glasgow scale only in group with low Glasgow scale, with a minimal operator, with a minimal debridement operation had a better Glasgow outcome scale. Our discussion, we have a similar studies which are done in Bolian was done a study in Turkey for involved 442 cases from 1992 up to 2008. There were male were the very dominant. Their age group was the main age group. Main age was 23 years, and their age range between 40 and 84. Time of arrival within 2 hours. All patients were treated operatively, and sharpening was the majority. The common site was in the frontal, followed by temporal. In our site was frontal, then parietal, then temporal. The mortality was higher in both stereofossa and the brainstem stem comparison to frontal area. It had a mortality rate of about 20%. In our case, it was 10%. The other study is Alison. It has 28 main age. He studied 136 cases. The mechanism of injury was gunshot in 31 and blast in the 69. The mortality rate was about 7%. Other study, it have a mean age of 29. Among the 9 patients were victims of suicidal blast. This study was done in Pakistan. and no mortality. The Glasgow outcome scale where 9 of 16 patients had a discharge Glasgow scale of 5, 3 patients had Glasgow outcome scale of 3, and 4 patients had Glasgow outcome scale of 4. This is another study was done in Saudi Arabia by during the Iraqi war, where 20 patients were studied. Most commonly located were frontal, and 7 patients followed by parietal. Admission Glasgow scale was 9, with Glasgow scale between 12 to 15, and 3 patients between 8 and 12 Glasgow scale, and 2 had Glasgow scale less than 8. Most of the mechanism were fragment in 17 cases. The other were bullets. 21 patients have an operative with extensive approaches only, and 1 case with conservative. Mortality rate was 4.5 cases. This is a long study was done in Finland for a long duration from 1968 to 1977 with 123 civilian gunshot, 47 cases, 16% were dead on arrival. 8 had no cerebral penetration. Cerebral gunshot made up to 2 of all head injury. The causes of wound were accidental assault, and suicidal was the most common in 87. Only 1 of 20 cases were older than 60 did not die. That means that all cases were above 60 were expired except for 1 case. The overall mortality was neurosurgery treatment was very high, about 79%. However, there was 620 deaths, which may increase the mortality rate with the civilian gunshot, and was estimated to be more than 90%. Our conclusion: there is a statistical relation between the dural injury, edema, and midline shift to the CT scan finding and the Glasgow scale, Glasgow outcome scale. Concentric, dilated, reactive, or non-reactive pupil were 100% seen in Glasgow less than 9, and 43 had full recovery using Glasgow scale, Glasgow outcome scale, and 29 with delayed disability, 14% severe disability, and 4 vegetative, and 10 died. 16% of mortality were caused by penetrating injury, while 40% caused by perforating. 80% of mortality causes were with Glasgow scale 8. Perforating injury had the worst outcome, and only about 7% had full recovery compared to 48% fully recovery in penetrating injury with a significant p-value. The better the Glasgow scale, the Glasgow scale, the better the Glasgow outcome scale. With the 71 fully recovered in mild Glasgow scale and only 11% recovery in a severe Glasgow scale patient, significant statistical relation between type of operation and Glasgow scale, Glasgow outcome scale only in group with low Glasgow scale with minimal operative or minimal debridement had a better Glasgow outcome scale. Our recommendation protocol for penetrating brain injury should be a guideline for management of all penetrating brain injury and should be imposed in all primary health care and emergency department and field of competence. Penetrating brain injury need patients and meticulous planning. Indication for surgery must be clear, and if possible, conservative management should be aggressive surgical removal of foreign so that fresh atherogenic deficit can be avoided. Surgical exploration, if needed, should be done by the expert only and must not be complete in half. The type of surgical intervention should be taken carefully depending on the general condition of the patient, indication, pathology, on scan. Also, you don't forget the availability of the resources, neurosurgical and other. The training for the medical staff for primary care services, how to deal with such injuries at the field of combat, at emergency medical care department, emergency department. our surgical care of patients with traumatic brain injury caused by penetrating injury is not optimal. Rapid transportation to hospital and urgent surgical intervention should have reduced mortality rates. Conservatively treated patients should be evaluated in well-equipped neurosurgical ICU and continuously monitored by intracranial pressure monitoring if needed. More multicenter study for penetrating brain injury included the military civilian patients all over the country. Thank you.
Thank you very much, Dr. Anand, for the very amazing presentations and a lot of amazing case. So I believe that Dr. Summerhurst is here now.
Oh, I don't know if Samar's here. Samar, are you there? Okay, okay. Alex, go ahead.
Okay, so
You can,
does
you can,
anyone have questions? Maybe you want to add with questions first? Anyone in the panelists have questions? Or maybe we can wrap up at the end of the presentations, okay?
okay, maybe ask Oleg who he wants to go next, Alex, maybe, okay? Oleg, who would you wish to go next?
I think
Is one moment. Is Dr. Hotz is here with us or no?
Let's see.
I don't see him. Abdullah.
Yeah, Samar, are you here? He was here. I'm sorry about this. Okay.
Close. Sasha.
Da.
I'm not.
I ready. Okay. Dr. Son.
Oh, yeah, okay.
Dr. Son is ready. Okay.
So please introduce yourself and away you go.
Let me introduce Dr. Son, Professor Son. Professor Son is the chief of neurosurgery in Odessa University. Experienced neurosurgeon, good friend, vice president of Ukrainian Association. So he deals with the trauma, with military trauma as well, and he wants to present us his cases. Just the cases. So, Dr. Son, let you please start.
Good afternoon, my colleagues, dear friends. Do you see my presentation?
Yes, perfect.
Yes. Okay. Okay. I'm not John Bennett. I'm Anatoly Son from Odessa. Now Odessa have this view because we have art. I present two cases of military neurotrauma. First case, Ukrainian soldier, 20 years old. He received a brain injury due to rocket shooting at the area of the Zmyny Island one day before entering to university clinic. This CT for entering to clinic. Neurological examination, Plaza scale 13-14, moderate right hemiparesis. Surgery, left resection trepanation, removal of the bone fragments and intracerebral hematoma with brain detritus. The right side metal fragment was not removed. Now you see. Oh, sorry. Post-op condition without deterioration. Patient transferred to the rehabilitation center. Secondary cranioplasty is planned. It's after surgery. First day after surgery. Okay. And next case. Ukrainian military pilot received the brain injury during a combat flight of the area of the Zmeiny Island one day before entering to the university clinic. CT performed on the day of injury. Neurological examination, glaucoma scale 30-40, meningeal signs, light speech disorders. One day control CT, hematoma enlargement, midline shift to the right and basal system narrowing. Immediately after CT, the condition worsening, glaucoma scale 11-12, aphasia, hiccups. Immediately left the compressive trepanation. Removal intracerebral hematoma with brain detritus. The bone fragments was not removed. The condition has improved. There is no speech disorders. The patient transferred to the rehabilitation center. Secondary cranioplasty planned. 2 weeks after surgery. Questions. Resection or decompressive? Second, which bone and metal fragments should be removed? 30, is primary cranioplasty necessary? And my conclusion, resection or decompressive trepanation is chosen individually for each injury. Not all bone and metal fragments should be removed. Primary or secondary cranioplasty is chosen individually for each injury. Absolutely necessary equipment, CT, operation microscope, trepanation system, aspiration, bipolar. Thank you. Glory to Ukraine.
Dr. Son, thank you very much. Pollux?
Oh, okay. Thank you. It's very nice. Maybe move to another speaker, Dr. Yaroslav. He will talk about the management of the combat peripheral nerve injuries.
Yeah. Hello, everyone. Hello, dear colleagues. Thank you for the opportunity to present my work. Unfortunately, this topic is really relevant and actual now, especially in Ukraine. Just give me a few seconds to launch my presentation. It's here, and 1 second for the screen demonstration. Yeah, just 1 second. Can you see my presentation?
Not clear.
Not yet,
yeah.
not yet.
Start,
Yes.
start again, please.
Oh, thank you. So the topic is
Oh,
management.
your presentation is not showing yet, please.
Oh,
Can you try again?
Yeah, you have to share. Dr. Summer is here.
yeah, sure. Just 1 second. What's wrong? Just one
Take
second.
your time.
Okay, we can see now.
Oh, perfect. I'm sorry
Perfect.
for a slight delay. So the topic is management of peripheral nerves combat injuries. Well, gunshot wound of peripheral nerves is separate type of combat injury caused by a projectile from a firearm, air gun, or other type of guns. So the relevancy of the topic is next. First, we need to admit that now, in recent decades, there has been a significant evolution of ammunition, which cause massive destructions of tissue, especially of our limbs, and affecting peripheral nerves. Due to the use of helmets and body armor, limbs become one of the most vulnerable parts of the body. And most of these patients are disabled after the trauma and has a severe psychological disorders. So what are the features of modern warfare? Up to 75% of damage is caused by different agents. Just one second. In most cases, it is a combined injury to the extremities, and it occurs in 70% of cases. Injuries are often complicated by critical bleeding and shock, and also injuries are possible in areas clearly distant from the immediate site of the wound. Just one second, next. A few words about epidemiology. The number of wounded with damaged nerves during the First World War ranged from 1.5% to 5%. During the Second World War, it ranged from 8 to 10%. But in modern wars, the number of wounded with damaged nerves ranges from 9 to 25%. Also, there is approximately the same ratio of lesions of the upper and lower extremities, and more than half of victims remain disabled, and up to 80% are unfit for further military service. So what is the nature of gunshot wounds? One factor injuries, it is violations of tissue integrity from direct action of the projectile, and multifactorial injuries. It's rising from the direct action of shells, blast waves, explosive gases, secondary shells, and of course, thermal explosion from high temperature. It is determined that the peculiarity of gunshot nerve injuries is the unevenness of the lesion in different areas, at different levels, in different anatomical areas. So every patient requires personalized approaches to the treatment. Next one. So what are the features of explosive lesions? A distinctive feature of most explosive injuries in the combination of complete or incomplete separation of one or more limb segments, the presence of large tissue defects with local burns, open and closed bone fractures, general contusion and injuries, and of course, both ammunition fragments and secondary wounding shells. The results of surgical treatment of peripheral nerves, gunshot wounds are often unsatisfactory, which is primarily due to the extent of damage of the nerve trunk, the presence of intra-trunk scarring tissue, impaired microcirculation due to frequent injuries of the vessels and nerve vessels, and significant damage to surrounding soft tissues. Also, we need to mention, it's very important that as a result of successful treatment of this category of wounded, the combat order of the active army is replenished with a big number of most experienced fighters. And conversely, the failure of medical rehabilitation of effective servicemen, civilians, is a heavy burden for disabled people. I want to present the ratio of the upper and lower extremities. It is our experience. So the percentage of upper extremities injuries is approximately 47%, and lower extremities is 53%. As we can see, and as it was mentioned before, the statement is real. So we have almost equal ratio for the upper and lower extremities. And here you can see the ratio of nerve damage and gunshot wounds to the extremities by the nerves. The most often we can see the injury of sciatic nerve, common peroneal nerve, brachial plexus, and ulnar nerve. Again, it is our experience. So for adequate restoration of lost functions, we need to provide an adequate neurophysiological diagnosis of the level, type of the damage, the degree of pathological process, and it depends on the choice of surgical treatment and some possibilities of conservative therapy. So what are the basic requirements for surgical access? First, is the possibility of sufficient examination of the nerve at the level of damage in the proximal and distal directions. The ability to expand the operating field, if possible, minimal traumatization, minimal cosmetic defect, and maximum preservation of intraneural anastomosis with the selection of damaged and intact nerve bundles. It's very important. So here you can see the macroscopic intraoperational examination of some examples of gold standards of peripheral nerves surgery is nerve suturing or neurorrhaphy, neurolysis of the structures of the nerves, or a nerve grafting. Also, it is widely used such methods like nerve transfer. We'll talk about this later. And I think it's quite important to name all the conditions of performing surgery for traumatic injuries of peripheral nerves. In my opinion, it's very important that the surgeon who provides this intervention has have to be really experienced one, because his mastery of microsurgical techniques, his perfect knowledge of the anatomy will give an adequate and good result after the surgical treatment. Also, it is clear statement that operating microscope is required with microsurgical instruments, suturing material, and adequate equipment for intraoperative electrodiagnostics, and of course, adequate anesthesia. So I want to tell just a few words about the methods of additional research. Of course, it's clinical neurological using scales, neurophysiological complex of preoperative diagnosis. It is EMG and ENMG, electromyography, electroneuromyography, intraoperative diagnostics, and of course, neuroimaging methods of research. So what are the features of gunshot wounds of nerves? First is preservation of the anatomical integrity of the nerve with complete loss of its function. It can be possible. The second is significant nerve defects and of course, polystructural injuries, because gunshot injury, it is not an isolated injury of the nerve. Of course, we have very severe defects of soft tissues, blood vessels, muscles, etc., and of course, bone fractures very often. And of course, a significant percentage of gunshot wounds accompanied with severe pain syndromes. Let me just tell you that according to our personal data, the pain was manifested in 78% of injuries, and the intensity was from 5 to 10 according to VAC scale, a visual analog scale. Of course, nerve damage complicated by neuropathic pain, amputation pain syndrome, phantom pain syndrome, and complex regional pain syndromes, which are quite common. Also, we use the method of surgical treatment like implantation of long-term electrical stimulation of peripheral nerves. Here is our Ukrainian system, which is used maybe, I think, more than 15 years. Here you can see the example of neurolysis of brachial plexus and simultaneous implantation of these long-term electrostimulating system. So what are the indications for the use of this electrical stimulation technique for gunshot wounds of peripheral nerves? First, this is the patient. It is indicated for patients with persistent neuropathic pain syndrome, also consequences of damage to the humeral plexus by the type of exanthemesis, consequences of obsolete trauma of the brachial plexus. It's useful for patients with positive results of reconstructive surgeries which were made before in the early stages of treatment. And when we want to see the expansion of the functional capabilities of the loss function of limbs by strengthening the function of certain nerves. And also we can use it in some cases after some insufficient decompression, which was made before. Here is a test simulator. We can use it for the programming of the different, we can choose some amplitude parameters, voltage parameters, personally, individually for every patient. And a few words about the advantages of this system. Of course, it's targeted stimulation of selected structures, painless stimulation, non-contact stimulation, and it is very convenient for patients because they can stimulate themselves at home without any need to attend some hospitals and some departments to stay there in hospital for the stimulation. So let me show you the results of surgeries for gunshot wounds to the nerves. Just I'll tell you a few words that unfortunately bad results and moderate results was achieved in ulnar nerve, a gunshot wound, and a common peroneal nerve. The total number of patients was 138. And on this table, you can see the results of neurolysis combined with long-term electrostimulation. I want to mention that all the patients who underwent the method of long-term electrical stimulation achieved better results of restoring the movement function and the function of sensitivities of sensation. And let me show you the most significant results of our some cases after nerve grafting. Here is an example of the nerve grafting technique. It was a gunshot injury to radial nerve, median nerve, and ulnar nerve. This is just like a protocol of the surgery.
Nggak ada aplikasi, dia
Here are the
nawarin.
photos
Ternyata ada
after
sekarang.
the surgical intervention. And here are the intraoperational photos. You can see the sural nerve vesicles for closing the gap between the distal and proximal stumps of medial, radial nerve, and ulnar nerve. And here, which is very important, 7 months after operation, you can see quite good results of wrist extension, which is quite good result due to the severe trauma. The next one is an example of muscle transfer. It was a gunshot injury to radial nerve, and we use the transfer of pronator teres muscle to extensor carpi radialis brevis, also palmaris longus muscle to extensor pollicis longus, and flexor carpi ulnaris to extensor digitorum communis. Again, it is the scheme of the operation. Stages of muscle transfer, just immediate photos after the surgery. And I want to mention that the great advantage of muscle transfers that we can see the result on the early stages, on the early terms after the surgery. So as you can see, very nice results after 1.5 months after provided surgery. So let me show a few more cases. This is distal nerve transfer of median nerve. Just it was an injury, gunshot injury of radial nerve, especially of its posterior interosseous nerve. So we made a transfer, a branch from medial nerve. It is branch for a flexor carpi radialis to posterior interosseous nerve, and also simultaneous muscle transfer of pronator teres to extensor carpi radialis brevis was performed. I want to mention that for the last maybe 5 years, from 3 to 5 years, we really enjoy this method, because when we have an injury on the proximal side of the limb, especially gunshot injury, traction type injury, the standard methods like gold standards, like just nerve grafting or nerve transfer on the proximal side can be not effective. So as for the distal nerve transfers, here you can see the intraoperational photos, and you remember that we provided also, in addition, the muscle transfer. Here you can see that just 1 day post-operational results. Slight movements of the wrist, dorsal extension, 1.5 months after operation. So here is 6 months after operation. You can see the extended range of movements, and 1.5 years after the surgery. Very nice function restoration. All the range of movements of the wrist is present. Another example of distal nerve transfer, it was a gunshot injury to ulnar nerve, especially the deep branch of ulnar nerve, and we provided the anterior interosseous nerve transfer for the deep branch of ulnar nerve. So here you can see the intraoperational photos, macro. Also one more example of distal nerve transfer. It was an injury of radial nerve, gunshot injury, and we made radial nerve branch of extensor carpi radialis brevis for the anterior interosseous nerve. So I'm sorry, it was an injury of median nerve. Here you can see the intraoperational photos and the results. The result is after 6 months post-operational. These muscles are innervated by medial nerve. So again, I think excellent results. So a few words about lower extremities. This is an example for distal nerve transfer after the injury of tibial, common parallel nerve. So we made a distal nerve transfer and simultaneous transfer of muscle of musculus tibialis posterior. So again, intraoperational photos and results. It is 3 months after the operation. Just a slight movement of the foot. I want to mention that it was a total loss of movements before the surgery. It is 6 months after the surgery and 9 months after the surgery. So again, quite a good result. And last example of the gunshot injury to femoral nerve. We provided a nerve transfer of obturatorius nervus and simultaneous muscle transfer of semitendinosus muscle to quadriceps. So here are the intraoperational photos, and we are still waiting for the results because this surgery was performed just 1 week ago, and just stages and photos after the surgery. So what are the conclusions? Surgical interventions for gunshot wounds to peripheral nerves can be delayed, and they have to be carried out only in specialized institutions. The results of surgical treatment of gunshot wounds of the peripheral nerve system are generally worse than in comparison to other type of injuries. Nerve damage as a result of gunshot wounds in 78% of cases are accompanied by severe pain syndromes. Long-term electrical stimulation of damaged nerves is an effective method of providing adequate regeneration in injuries such as axonotmesis. Again, long-term epidural electrical stimulation is an effective method of controlling pain, especially in patients with complex regional pain syndromes and phantom pain syndromes, and also the use of this method of long-term electrical stimulation of nerves and plexuses provides a significant improvement of the quality of life of such patients. And the last one, the use of distal nerve transfer techniques is promising and effective method of treatment of proximal gunshot wounds of the extremities. I'm very grateful for your attention. Thank you.
Thank you. Thank you, Dr. Tsambalik. I'm Dr. Samar House. I'm originally from Iraq. I'm now practicing in Cincinnati, Ohio. The last presentation was really interesting. I want to know the schedule from Volerix. Should I start or we will have discussion at the end? What do you prefer?
So now it's like we just every speaker to like give all the presentations. So now it's time for the Q&A, questions and answers. And you may proceed for your topics, or you want to give group discussions, or any person want to give an opinion or yes.
Okay, so I will give the presentation in a short time. I think it will take 7 minutes. Then we can have a discussion. I have some comments, and I want to ask Dr. Adnan, Dr. Son, and Yaroslav about their presentation too. If it's okay, I will share this slide. Slides, okay?
Yes, perfect.
Yeah.
Okay.
Great.
So while preparing for this presentation, it's like three direction in mind always, and while presenting about these topics. The first is the trauma surgeon that want to manage the really urgent case. The second pathway is the researcher that has the desire to document all the data, anything about these disastrous injuries so he can make analysis in the best way possible. And the third one is the supporter for peace in general. I'm from Iraq, so I have a really tough experience with the trauma in general. And I think I'm from Baghdad initially. Baghdad is the hottest spot around the world regarding injuries, civilian injury, military. For military and civilian, I think it's quite mixed according to where the battle is. Nowadays, most of these are within cities, so these are more mixed injury. And I goes with the Dr. Adnan, I think, that yeah, there's a difference between civilian and military. I think the major difference with this type of injury is the military injury is more expected, so the victim can protect himself.
Excuse me, Samar, your slides are not moving.
Yeah, I will move to the next slide in a few seconds.
Oh, okay, I'm sorry.
Yeah, okay.
I'm sorry about that.
No problem. So I always start my presentation with this slide. It's the gratitude to our teachers. And yeah, in general, I'm not here to discuss the principles of head injury, the different type, primary injury, secondary injury. I think, yeah, there is a lot of illustration demonstrate how variable this type of injury can be. And what I will focus on mainly two main topics: blast-related injury. I think this is the focus of military civilian injuries, because these are the most common as compared to other types during war. And also, let's say, sharing a different experience from Iraq with canisters. So blast-induced traumatic brain injury is a huge incident. The main difference from the regular traumatic brain injury is that the mass casualty is that there is several patients presenting at the same time, need the same treatment, and you have limited surgeons and limited ORs, whatever the center, however it's well equipped, still there is a maximum limit. So we will focus on 3 or 4 main topics about how we define damage control surgery and the concept of neurosurgery, how to devise a tailored triaging system. I think that triaging system that we use is quite unique, and its uniqueness come from the continuous modifications over the time. And I mean unique because it's the thing that we use locally. I will share it, and everybody have his opinion and can modify accordingly. And yeah, let's go with the, we will present the blast traumatic brain injury. In general, there is an increase in the incidents, more terroristic attacks, civilian military, we discussed this, and the mass casualty is the main or is the critical issue here. There is the car bombing is the causative agent, and usually these are heavy explosives. This is from Iraq experience for sure, and maybe applied in general for explosions. And yeah, we have a lot of losses. The difference in blast injury is that there is the 3 waves. There is a primary injury for around the blast area, then the secondary injury from the shrapnel that pushed away and may affect many people, and the third type is the tertiary injury, which may include that the patient is just pushed away to be hit to the floor or to the buildings. So we present this based on experience from the deadliest suicidal double car bomb attack in Iraq. And yeah, the incident was in 2009, and it's 2 suicidal truck bombs, and the victims were 152 and are dead, and 520 injured. I think the 520 is the real number that we are dealing with. In our center in Baghdad, it's the main trauma center all over Iraq, and this is what we have. We receive, that's the main point, we receive 75 patients at the same time to the emergency department. After initial resuscitation, 19 died and 56 were admitted to the hospital. Those were either treated by surgery. 39 patients have surgery within 3 or 4 days. So we have continuous OR work for these 3 to 4 days, and others are treated conservatively either in the regular ward or in the neuro intensive care, and the final outcome was variable. There is a 17 death, and the good outcome is 31. So if we had in mind that those patients, those sample are the less injured patient because they have the opportunity to survive until they reach the hospital. So we can imagine how disastrous these type of injuries. And yeah, I will not go through the characteristic that we already studied, but just to highlight that there is a lot of modification. Even it's not a decompressive craniectomy only. What's the subtypes of decompressive craniectomy according to the lesion? If we have a brain tissue out, we usually remove this herniated brain, but it's according to where it comes. So we analyze that also for the whole 75 patients, and we also do subgroup analysis. However, the result for subgroup analysis are not quite significant, I think, because of the variability of sample. So this one of the main concept that I want to focus on is that we already know that there is a damage control surgery in the management of trauma, but as it's applied to neurosurgery, we think that it will consider 6 or 5 or 7 main steps according to the patient, and should be individualized. In general, elevation of the press fracture, removal of the accessible shell. I think Dr. San focus on this. Hematoma evacuation, cleaning and debridement, then hemostasis. If it's a dural repair possible or not, through primary repair, or sometimes we leave it for a second or for a later surgery. And yeah, that's the discussion. The triaging system, I think that's the unique one that we have like a team with different tasks. It's different from the regular team. This team just started once we know that there is a blast injury and we will receive a mass casualty or receive many patients. At least 10 patients. So we make this. So in the emergency department, we will have 2 neurosurgeons and 4 residents receiving the patient, doing the ABCDs, the initial resuscitation, because this is very critical. Next step to the CT scan. At the CT scan, there is not only a radiologist, but there is also a neurosurgeon in the CT scan to take an immediate decision. That's very important, because from the CT scan unit, the patient will be either drifted to other hospital because they have more serious associated injuries than the head injury, or go to the next levels inside the hospital for admission. And the ICU, also that's different. It's not for anesthetist only or a neurointensivist. We have a neurosurgeon should be in the ICU and 2 residents. The idea is to continuous triaging and deciding what's the post-resuscitation GCS, and then decide what's the patient that should stay in the OR. Sometimes the CT scan indication of surgery. However, the GCS after resuscitation not improved, still GCS 3, so this surgery will be canceled. That will make the priority for the patient in the best way possible. I think all of you understand that this is working with limited resources, and I also stress that limited resources will be everywhere, because this is unexpected type of trauma and will be present in many patients at the same time. In the OR, we have 3 OR running together, each OR with a neurosurgeon resident. We emphasize the presence of a neurosurgeon at each step of the whole triaging system, and especially in each OR, because in trauma you need to take instant decision to sacrifice this, to make a frontal lobectomy or not, to arrest venous sinus bleeding. These are should have a momentary decision and should be treated as soon as possible. So we suggest the presence of a neurosurgeon as much as possible in each case. For that experience, we have 4 days of 3 OR running at the same time, and we operate on 39 patients. I think that's one of the toughest experience that can occur. And yeah, I will not go through the details. I think Dr. Adnan and Dr. Sanu present some cases, some interesting cases, and it's quite variable. And that's about the blast injury. That's what I want to discuss. Just to give you an idea, I want to share this different type. Usually it's not a high velocity because it's a tear gas canister. This should used for the against demonstrations. So it's also civilian, but in Iraq, before a few years, we have anti-demonstration tear gas injuries, and we have 41 patients injured with head injury due to tear gas canister. It's a rare experience. I think it's the first reported around the world. And 10 of those patients have completely intracranial tear gas canister, which is quite strange. And yeah, this type of injury, the tear gas canister, how it entered the skull, how it's caused this penetrating injury, it's a disaster actually. And how to manage such a huge mass inside the brain, you can imagine it's not a regular bullet, it's a bullet by at least 10 to 20 times of the size. And there is it was a tough experience and tough decision. Sometimes actually a few patients, we do not remove it at all because it's on the torcula. While those patients, no, we can remove it. Even the CT scan for neurosurgeon, I think this CT scan is strange. What's this foreign body? It's not metallic, obviously. However, it penetrates the skull. So it was a different experience. And the cause, I think after investigation, it was a military type of tear gas canister or tear gas bomb. So this type of weapon should be not viewed as a less lethal weapon or less serious weapon. This has just a variety of injuries and how can put it. Something interesting, I don't know if it's helpful or not. And for Ukraine, we have in Iraq, I don't know, some of the non-governmental organization built the Iraq body count, and it summarized all the injury according to what weapon use, if it's bullet or blast, what's the area in Iraq. And this can be very important for future research and analysis for the injuries. And yeah, just a few concepts that the brain tissue out concept. I think all the surgeon managing trauma know this is a very common thing to face, but we find there is not much about it in the literature. I would suggest to analyze it more according to your series and your centers. And yeah, the research thing, that's what I want to, why I already put in the beginning of presentation that, yeah, sometimes you want to be the researcher that you want to analyze every type of injury to make impact for the future. And sometimes you need to be the surgeon that's managing those patients in the emergency setting. Our duty in life to support each other and make the next generation even better. I hope this will be helpful for some people. However, it's very simple concepts, and thank you.
Thank you, Dr. Haas, for very amazing presentations and the case, and always like very nice take-home message. And I'm your fan club, especially vascular. Okay, so does anyone have questions? Please feel free to open your cameras and ask Dr. Haas or the previous speakers questions.
Valerie, can I comment?
Oh yeah, sure.
Okay, so first of all, thank you for your presence and thank you for the panelists, and thanks for John for making this happen. I think discussion always important for everybody, and once you present your work and see other presentations, you will have a new idea always. If I can ask, I will put just a question for each of the presenters. If Dr. Adnan available, I will ask about the early versus late presentation. In another way, the distance of the treating center from the injury area or from the combat area, let's say, what's the difference, and how is that different according to his experience? Dr. Son, yes, I think the three questions that he put, it's very evident. However, I want to ask his opinion, personal opinion about resection versus decompression, because I think it's very individualized and some surgeons have the intention to do decompression more. And for Yaroslav, I will ask what's his background of anatomy, because I think that peripheral nerve surgery need another level of anatomy, and a person of vast interest in peripheral nerve. So any one of the available presenter, I'll be ready to hear your comments, and thank you, Valerie.
Thank you.
Can I check I will answer the question for Dr. Samir. Thank you for your presentation. First of all, that time of presentation for our causality is different. We have a remote site of injury, which were maybe 6 or more hours from our institute. We are a referral hospital, not a first-line hospital for these causalties. And we are not a military hospital. We are just a referral hospital in Sana'a. We are mostly receiving patients from terrorist bombing inside Sana'a, or from airstrike inside Sana'a, which are close to us. That's most patients arrive to us in an early way, in hour or 2 hours, or referring from nearby hospital. So there is no difference between late presentation and early presentation in our study. But there is a similar military studies was done in Iraq, which said the first line medical health services will have impacted in the outcome of patient, first time for resuscitation, and do ABC for resuscitation of the patient, will improve the outcome of patient survival rate. And believe me that the severe cases maybe will not reach our institute or the first line primary health. They will expire in the site of injury. We have no information about these cases, so to include it in the study. Thank you.
Thank you.
Okay, thank you very much. Dr. Son, are you with us?
Alexander, I'm here.
Yes, you have a question concerning resection and decompression.
Yes.
What is more preferable?
I think resection and decompression is individually. And first is patient condition. First, if you have patient condition with Glasgow coma scale 11, 10, and down, I think only decompressive, not plastic, primary plastic, because this patient have good chance for morbidity and mortality. And plastic, we in these cases, in these cases, we planned secondary. And about maybe about bone and metal fragments. If you see first patient, we don't remove metal fragment because this metal fragment was in another site, and surgical trauma maybe more than our surgery. And second patient. Now we have only two patients in our clinic with combat trauma. And second patient, if you see, have some bone fragments near vena laba, and I think not necessary remove this fragment near vena laba, and more important, decompressive and hematoma remove in this case. Thank you.
Thank you. Any questions? Any comments? So
I have a question.
yes,
So,
go
do
on.
you have, what is the pre-operative antibiotics that you usually give to the patients before you operate?
And the questions?
This question.
What is the antibiotics that you usually give the patients before you do the operations?
Okay, what this question for me?
and anyone's, or you
I know.
can consider that, you know, I mean, different. Yeah.
My opinion usually is necessary and prolonged antibiotic therapy in this patient, and intraoperatively, and preoperative, and postoperative.
Okay, Doctor Watts, are you satisfied?
Yeah, for sure. It depends on the case, as Dr. Son said. It's quite individualized, but still there is some surgical trends. It depends on the school. Let's say, from our experience, I think it's more related to the velocity of injury. The extremes are less risk of injury. I mean, the high velocity tangential, we will give a little antibiotic for 1 day or 2 day maximum. It will be at a very low risk, and at the other extreme, we have a special form called gravitational bullet injury, that bullet from the sky. So it's a bullet injury, but a very low velocity. Also, this type of injuries, it depends, but mostly has no specific indication for antibiotic. We are not encouraged to give antibiotic to those. Otherwise, let's say the common type of bullet in general, or especially the blast, I mean the shell injuries, are more, let's say, dirty injuries. So yeah, the antibiotic is quite considered. And as Dr. Son said, it depends on the case. It's your decision at the moment, more than a general guideline that I will give antibiotic now or not. I will start with IV antibiotic from before the surgery, even loaded. But yeah, in general, the shrapnel injury will require more than bullets. And however, I think the trauma cases, the reports suggested a late abscess incident in the old injuries. Yeah, but it depends.
So only for a couple of days, and it depend on the velocities of the points, right?
That's what I say by individualized, because sometimes if you have a CSF leak or a patient with high risk to be a CSF leak, that's inside the surgery, you know that the dura repair is not enough. Yeah, you will be encouraged to cover antibiotic. I will give the patient at least 2 weeks antibiotic. If I suspect that, yeah, it will be difficult for his dura to heal. I don't know the opinion of Dr. San.
Okay, so
Thank you very much.
thank you.
Thank you.
I have a small comment, please, about the use of antibiotic in our practice. For penetrating brain injury, we routinely use 3 antibiotics for anaerobic and aerobic and gram-positive, gram-negative. We cover these pathogens as the infection rate in our institute or in the country is high, and most of the expulsion injuries are dirty, as Dr. Samir said. They are not considered as clean injuries. They are considered as a dirty or contaminated injuries. So we dealt with at least for 2 weeks of covering gram-positive, negative, and also anaerobic bacteria. Thank you.
So it's individuals.
Actually, there's a couple of questions, Rourke. Do you see them? Do you see the questions? Here, let me copy and paste them.
About this,
Epilepsy.
yes, we have in our institute or in our study, we have about 4% of post-trauma epilepsy, which is late. We are speaking about the late development of epilepsy post 6 months of injury. We have 4% rate of late epilepsy. Early epilepsy, we already put cover for give anti-epileptic from the time of admission till time of discharge. We will stop the anti-epileptic after 6 months of discharge if there is no convulsion. If there is another convulsion after 6 months or after stopping the anticonvulsion, we will prescribe an anti-epileptic for life. I hope I answered this question.
Yes, thank you.
There's a comment by Roman. What is your usual approach for preventive prescriptions of antibiotics?
Yes, answer.
Answer that.
Okay,
Answer.
that's why we need a moderator. Okay, go ahead, Warlix.
Another questions from a guest, but I don't know is that the answer or actually he said that maybe is there the role of the steroid and the TBI? Is that a questions? If Dr. Minasha here, I don't know is that question. Oh, I have a question. So
Okay.
In what type of case or when you're going to follow up with the angiogram or CTA brain? Yeah, maybe sometimes it's when in the first CT is really metal like scatterings, and I don't know, it's like, and sometimes the lesion is very big, but maybe we have to operate it before we can perform the angiogram or CTA. But I want to ask like how when will you going to follow up CT angiograms? Or finding any like vascular injury?
So Valerix, bring the question always to vascular. I will give my opinion first and see that. I'm kidding. So I will give just a comment and we'll wait from the panelists their opinion. In general, two incidents in my mind, if it's a bullet near the carotid exactly, that the patient I will concern about and I will try to follow him in any way possible. Or the second option is that a patient with vascular injury that I repair intraoperatively. Some intraoperative bleeding in trauma, and sometimes the cause of death intraoperatively, usually from venous side, not from arterial side. It's rare from arterial side, but if it's from arterial side, and I will manage it in any way, whether cauterization, suturing, or clipping, whatever, this patient will have a different pathway for follow-up. What I want to say that the patient who are victims for blast injury in general, the sharp panel, it's difficult to follow them. And there is a variety of injury. A lot of shells are still in the body. MRI not always possible. So yeah, unless they have a new presentation from the old injury, so we will not follow them. I see a lot of pseudoaneurysm research now. They are reporting the cases, but I think in our setting with the mass injuries and a lot of patients, it's difficult to follow them and to find if there is a possibility of pseudoaneurysm unless the patient is presented to you, and putting in mind that those patients, those victims, usually and most often are not from the region of the hospital, the region that the hospital drain. So they are from all over the country, and yeah, by this incident, they present to your hospital. So they are not living near from you, and their follow-up will be usually at a different institute.
Yeah, I see your point. Yeah. Yeah. Have to listen to the people who have the experience. Yeah, I agree. Mhm. Any other idea from other speakers?
I have some comment for concerning the city angiography. We usually perform it in patients with the skull-base fracture in the area of condyle, because there is always a threat of dissection of vertebral artery. It's obligatory. What we do, it's a small comment in addition to everything what Samar told. So, thank you.
So if they have a dissections, will you going to prescribe the anti-platelet or anticoagulant after you do the surgery, or still the bleeding? Yeah, the next question. If we just find that, because yeah, it can happen, right?
Good. So, okay, maybe let us finish.
Yes, very good, Doc. I'd like to thank you for getting all this together. And I'd like to thank Borlix for moderating and to all the speakers. And we look forward to doing more webcasts with the Ukrainian neurosurgical community. So
Thank you. Thank you for the
Thank you.
invitation also. Thank you.
Thank you for your contribution to Ukrainian victory. Thank you very much. Thank you.
thank you, everybody.
Glory
Stick
to
around. We're not going to
Bye-bye.
finish.
Thank you.
See you soon. Thank